Hello friends, greetings from RFA Tutors, your mentor this side with the Green Top Guideline of the day. Today we are here to tell you about the management of endometrial hyperplasia, the Green Top Guideline number 67, published in February 2016. The revised 2014 World Health Organization classification is recommended. This separates the endometrial hyperplasia into two groups based upon the presence of cytological atypia, the hyperplasia without atypia, and atypical hyperplasia. The endometrial hyperplasia is often associated with multiple identifiable risk factors, and assessment should aim to identify and monitor these risk factors. The single best answer. Diagnosis of endometrial hyperplasia requires histological examination of the endometrial tissue. Endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy. The diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample, especially where outpatient sampling fails or is non-diagnostic. The transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre- and post-menopausal women. Direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. There is insufficient evidence evaluating computerized tomography, diffusion-weighted magnetic resonance imaging, or biomarkers as aids in the management of endometrial hyperplasia, and their use is not routinely recommended. Women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. Reversible risk factors such as obesity and the use of hormone replacement therapy should be identified and addressed if possible. Observation alone with follow-up endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. Women should be informed that treatment with progestogens has a higher disease regression rate compared with observation alone. Progestogen treatment is indicated in women who fail to regress following observation alone and in symptomatic women with abnormal uterine bleeding. Both the continuous oral and local intrauterine system progestogens are effective in achieving regression of endometrial hyperplasia without atypia. The levonorgestrel intrauterine system should be the first-line medical treatment because compared with oral progestogens, it has a higher disease regression rate with a more favorable bleeding profile, and it is associated with fewer adverse effects. If adverse effects are tolerable and fertility is not desired, women should be encouraged to retain levonorgestrel intrauterine system for up to 5 years to reduce the risk of relapse. Endometrial surveillance incorporating outpatient endometrial biopsy is recommended after the diagnosis of hyperplasia without atypia. Endometrial surveillance at a minimum of 6 monthly intervals, although review schedules should be individualized and responsive to changes in women's clinical condition. At least 2 consecutive 6-monthly negative biopsies should be obtained prior to the discharge, and women should be advised to seek a further referral if abnormal vaginal bleeding recurs after completion of treatment, because this may indicate disease relapse. In women at higher risk of relapse, such as women with BMI of 35 or greater, or those treated with oral progestogens, 6 monthly endometrial biopsies are recommended. Once 2 consecutive negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual endometrial biopsy. Hysterectomy should not be considered as first-line treatment for hyperplasia without atypia because progesterone therapy induces histological and symptomatic remission in the majority of women and avoids the morbidity associated with major surgery. Hysterectomy is indicated in women not wanting to preserve their fertility when progression to atypical hyperplasia occurs during follow-up or there is no histological regression of hyperplasia despite 12 months of treatment. There is relapse of endometrial hyperplasia after completing progesterone treatment. There is persistence of bleeding symptoms. The woman declines to undergo endometrial surveillance or comply with the medical treatment. Postmenopausal women requiring surgical management for endometrial hyperplasia without atypia should be offered a bilateral salpingo oophorectomy together with total hysterectomy. For premenopausal women, the decision to remove ovaries should be individualized. However, bilateral salpingectomy should be considered as it may reduce the risk of a future ovarian malignancy. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach as it is associated with a shorter hospital stay, less post-operative pain, and quicker recovery. Endometrial ablation is not recommended for the treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance. Women with atypical hyperplasia should undergo a total hysterectomy because of the risk of underlying malignancy or progression to cancer. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach as it is associated with a shorter hospital stay, less post-operative pain, and quicker recovery. There is no benefit from intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo oophorectomy together with a total hysterectomy. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered as this may reduce the risk of a future ovarian malignancy. Endometrial ablation is not recommended because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude endometrial histological surveillance. Counsel about the risks of underlying malignancy and subsequent progression to endometrial cancer. Pre-treatment investigations should aim to rule out invasive endometrial cancer or coexisting ovarian cancer. Histology, imaging, and tumor marker results should be reviewed in a multidisciplinary meeting and a plan for management and ongoing endometrial surveillance formulated. First-line treatment with the levonorgestrel intrauterine system should be recommended with oral progestogens as a second-best alternative. Once fertility is no longer required, hysterectomy should be offered in view of the high risk of the disease relapse. Routine endometrial surveillance should include endometrial biopsy. Review schedule should be individualized and be responsive to changes in a woman's clinical condition. Review intervals should be every 3 months until 2 consecutive negative biopsies are obtained. In asymptomatic women with a uterus and evidence of histological disease regression based upon a minimum of 2 consecutive negative endometrial biopsies, long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until a hysterectomy is performed. Disease regression should be achieved on at least 1 endometrial sample before women attempt to conceive, a very important extended match question. Women with endometrial hyperplasia who wish to conceive should be referred to fertility specialists to discuss options for attempting conception, further assessment, and appropriate treatment. Assisted reproduction may be considered as the live birth rate is higher and it may prevent relapse compared with the women who attempt natural conception. Prior to the assisted reproduction, regression of the endometrial hyperplasia should be achieved as this is associated with higher implantation and clinical pregnancy rates. Systemic estrogen-only HRT should not be used in women with a uterus. All women taking HRT should be encouraged to report only unscheduled vaginal bleeding promptly. Women with endometrial hyperplasia friends taking a sequential HRT preparation who wish to continue HRT should be advised to change to continuous progestogen intake using the levonorgestrel intrauterine system or a continuous combined HRT. Women with endometrial hyperplasia taking a continuous combined preparation who wish to continue HRT should have their need to continue HRT reviewed. Discuss the limitations of the available evidence regarding the optimal progestogen regimen in this context. Consider using the levonorgestrel intrauterine system as a source of progestogen replacement. Women taking tamoxifen should be informed about increased risk of developing endometrial hyperplasia and cancer. They should be encouraged to report any abnormal vaginal bleeding, discharge promptly. There is evidence that the levonorgestrel intrauterine system prevents polyp formation and it reduces the incidence of endometrial hyperplasia in women on tamoxifen. The effect of levonorgestrel intrauterine system on breast cancer recurrence risk remains uncertain, so its routine use cannot be recommended. The need for tamoxifen should be reassessed and management should be according to the histological classification of endometrial hyperplasia and in conjunction with the women oncologist. Complete removal of the uterine polyp is recommended on endometrial biopsy. It should be obtained to sample the background endometrium. Subsequent management should be according to the histological classification of endometrial hyperplasia. The Appendix 2 is the most important algorithm for the management of endometrial hyperplasia, both without atypia and the atypical hyperplasia as well. I'm going to discuss in detail, will make you memorize this algorithm in the live session. All the single best answers and the extended match questions, yes, they come from this algorithm. Some important exam points from this Green Top guideline are endometrial hyperplasia without atypia, management diagnosis of endometrial hyperplasia with atypia, and last but not the least, the most important, the management algorithm. Best of luck from the entire team of RFATUTORS. Thank you very much for joining us today. See you next time, and until we meet again, take very good care of yourself. Bye-bye.